So this could be very short, because if you say, what is the evidence to use biologics? At the moment, there's very little, but I hope I'll persuade you there's hope on the horizon. At the risk of sounding like a football fan, what do we want? We want rational targeted therapy related to pathophysiology, we want to minimize treatment-related toxicities, and we want to improve the quality of life of our patients. And to me, that's equivalent to getting rid of steroids. What do we have? Well, actually very little. I don't know what's available over in South America, but the licensed drugs to treat lupus nephritis in the UK are steroids, aspirin, and hydroxychloroquine. So when we worry about using biologics off license, it's worth remembering that we're using everything off license on a daily basis. And what do we have? The other recommendations that came out last year were the KDIGO, Kidney Disease Improving Global Outcomes. KDIGO is a renal organization which produces guidelines on everything renal and produced a very good set of guidelines on glomerulonephritis last year and a large chapter on lupus. There were 26 recommendations for lupus. Only 2 of them were level 1A, and that was use steroids and don't use cyclophosphamide, MMF, ACEs or ARBs in pregnancy. There were 2 1B that fit entirely with what we've just heard, which was start with cyclophosphamide or MMF and lupus nephritis, and there were 15 2D. 2D in KDIGO is we suggest, and that the data may be very far from the truth. And they include, we suggest that non-responders who fail more than one of the recommended initial regimens may be considered for treatment with Rituximab, IVIG or CNIs. So really very little data, and sadly there are 2 negative trials of biologics in lupus nephritis, the BMS atacicept trial and LUNA. But hope springs eternal. There is data to suggest biologics work. We all want the biologics to work, and actually I think most of us think Rituximab does work. There's registry data, there's cohort data, and there's hidden data in the trials. And if you look on clinicaltrials.gov, there's an awful lot of trials out there, so there are people thinking these agents can go. There are 28 trials that say they're recruiting for lupus nephritis, and there are 5 more that are active and not recruiting, and 35 completed, though I'm not aware of 35 trials that have influenced my daily practice. Of the ones that are due to recruit or are recruiting, 5 are just observational with biomarkers, 12 are with what I would call conventional treatment, including 8 with tacrolimus, 4 with stem cells, and then 10 with biologics, including 3 rituximab, 1 anti-BLyS, 1 anti-tweak, 1 CTLA-4 Ig, and 1 anti-interferon gamma. So we are moving towards thinking in a targeted way, and there are therapies coming along that target every point of the presumed pathogenesis of lupus nephritis. So we have the non-specific immunosuppressants, and you've just seen there's a lot of trials with tacrolimus. We're working quite hard on cell-targeted therapy with anti-CD20, anti-CD22 is eprotuzumab, and anti-BLyS. APC activation, CTLA-4, interferon alpha studies will come along, and anti-tweak. Not moving. But was it all bad news from the trials? And if there was bad news, why was there bad news? And these are 2, I'm going to focus on the trials that have looked at B-cell targeting in different ways. And so, well, CTLA-4 Ig, abatacept interferes with CD28, and it's rational to use this. It's biologically plausible, and the murine studies were very promising. CD28 engagement on T cells required, is required for activation of primary T-dependent immune responses. CD28 engagement on long-lived plasma cells is critical for their survival, and abatacept was effective in murine models of lupus nephritis. So it was an interesting one to take forward, but there was a negative trial. And as you heard yesterday from Richard Fury, that was almost certainly because the bar was set too high for the endpoints, and there was an error in the endpoints. So what David Wuss has recently published is a very beautiful re-exploration of the primary data, but applying the endpoints that have been used either by ACR or the LUNA trial or the ARMS trial or his own CTLA-4 access trial. And what you see there is you start to apply more clinically meaningful and achievable endpoints, you start to see a real difference between placebo and control. That's illustrated here for all comers in the trial. But if you go, as Joe Merrill was saying, for the more severe patients, then you see an even bigger difference. So if you look at the different outcome measures in the nephrotic patients in the original BMS trial, you start to see deltas that you would be very happy with for taking this forward. And that's shown, that's summarized on that bottom graph there. So the lessons learned from that trial: don't set the bar too high. You need clinically meaningful endpoints. You can't be too loose and fuzzy, but a PCR of less than 0.5 is acceptable as a complete remission, not less than 0.2. Do not use the urine sediment in your endpoint, and creatinine should be normal or within 20% of baseline, because if patients start with scarred kidneys, you're not going to improve that underlying scarring. And you may, in a disease where you can't get rid of background therapy altogether, as Joe Merrill was saying, you may be better off looking for your signal in more severe disease. The LUNA study was the great hope and was a negative trial on its primary endpoint. It went for a big delta. It was a relatively small trial. It went for a clinically meaningful endpoint. It looked at 52 weeks, but it aimed high, with a 20% delta in complete and partial remission, but with major weighting towards complete renal remission at 1 year. And there was a non-significant difference in complete remission. There was a trend in partial remission, but it wasn't powered to show that. But there was quite a lot of positives in that trial. There was the biologically plausible bit, which is that the serology normalized significantly. But at the exploratory endpoints, there was at least a 50% reduction in proteinuria that was significant in the Rituximab group at 78 weeks. So there was divergence beyond the 1 year endpoint. There wasn't significance, but there was numerically a big difference in the response of the black patients, who are traditionally a very difficult group to treat. But it wasn't powered to show that as significant, but it looks tantalizing. And what was quite important was the need for additional immunosuppression was significantly different at week 52 and week 78 in the Rituximab group, again suggesting that there was effect. They say there's significant difference in dose of steroids. As a steroid avoider, I'm very unimpressed by reducing from 12 to 10, but it was a significant reduction in steroids. And importantly, as an add-on study, there were no new safety signals. So the lessons from LUNA were: don't set the bar too high. You still need clinically meaningful endpoints, so exactly the same as abatacept. And a complete response rate at 1 year is fine, but a delta of 20% may be too high and in an add-on study unless it's a huge study. And you might be better off, again, going for severe disease or go bigger or longer to see the full benefit. The belimumab trials, the anti-BLyS trials, were not renal trials and indeed excluded patients with more than 4 grams proteinuria, but they included, in fact, quite a lot of patients with significant proteinuria who were possibly informative. And if you look at that data, and it wasn't powered, and these aren't significant data, but if you look at the patients with renal remission, this has just recently been published by Mary Dooley, you see that there is, if you look at the placebo group versus 1 mg per kg and 10 mg per kg of belimumab, there appears to be a trend with patients more likely to achieve renal remission in the higher dose belimumab. They're more likely to do that quickly. They're less likely to flare, though the overall flare rate was very low in this study. And if you look at anybody who had proteinuria of greater than 0.2, which is quite a low level of proteinuria, those on belimumab seem to have a greater reduction in proteinuria. So there's quite a lot of data hidden in that trial that suggests that BLyS may be useful in lupus nephritis, and indeed there's an ongoing trial to assess that. The BLyS lupus nephritis trial, apologies for the spelling mistake there, a phase 3 randomized double-blind placebo-controlled trial to evaluate efficacy and safety of belimumab using the 10 milligrams per kilogram dose versus placebo. It's big. So they've learnt from the trials. They already had learnt that with their first 2 trials, 464 patients. It's a soft endpoint, it's a renal response, but it's gone long, so week 104. So lots of lessons learned there with appropriate secondary outcome measures. What else would we like to do? Well, we know that inflammation is terribly important, and an interesting molecule is an anti-tweak, because tweak has been shown to be very important in models of lupus nephritis and related to the pathophysiology. It's expressed primarily as a soluble cytokine but infiltrating leukocytes. Its receptor is expressed in the kidney and upregulated, and tweak is pro-inflammatory. Urinary tweak levels correlate with lupus nephritis activity and flare, and there's upregulated expression on infiltrating cells in lupus nephritis biopsies and upregulation of the receptor, and it acts at all levels of the renal pathology in lupus nephritis. So it's a very attractive model, and the animal models were a molecule, and the animal models were suggestive of benefit. The phase 1 went well, and there's now a randomized controlled trial, the ATLAS trial. It's using it as an add-on, but it's waiting. So it's learnt. Perhaps what you need to go for is the more refractory patients. So looking for your biggest signal in the patients who would otherwise not do as well. So waiting, if they've still got proteinuria, I believe at 3 months, then adding on the tweak or not, a placebo at that point. And the primary endpoint is 1 year, complete and partial remission, 3 arms with 2 doses. They want 300 patients. And so they've learnt the lesson of perhaps going for a targeted population within your lupus nephritis, because they want to use it as an add-on to increase the proportion in remission and the time to remission. But there is a problem, because we have a real discrepancy between clinical trials, clinical studies and trials. If I got you to do a show of hands, I suspect a lot of you use Rituximab, I certainly do, and have been using it as a rescue therapy. And the registry reports would support that. And I just give you an example from the biologics between Spain and the UK. And they looked at patients who had had off-label use of Rituximab, and the majority of these patients were getting it as a second line, sort of refractory nephritis, and there was a complete or partial therapeutic response in 67% of patients at 12 months. So really quite strong data, but the LUNA trial didn't show that. Fred Husau's trial is going to address that, the RING trial, Rituximab for lupus nephritis with remission as a goal. And the rationale is that we don't know where to use Rituximab yet. The data suggests that it's going to be good for refractory lupus nephritis. So he's going to determine whether the addition of Rituximab to standard of care is more efficacious than continued standard of care alone. It's not there to treat flare. It's a multi-center, investigator-led study, randomized, open, multi-centric study. Fred is the lead, but with colleagues from around the world involved in this. And you can go into it whether you're an instant patient or a grumbler. The patient's getting cyclophosphamide, or they've been on azathioprine or MMF for 6 months. And if they still have proteinuria at 6 months of more than 1 gram, then they're randomized to get Rituximab or not. And they get pulse with Rituximab, and he's gone for the long endpoint, 104 weeks, for complete renal response. So a good hard endpoint at a long time point should say, does Rituximab add to therapy when you add it on in refractory patients? It's a superiority trial. It's been designed to detect a difference in favor of Rituximab of 20%. So again, the bar's quite high, but at a long time point. And they need 97 patients. So it should define the role of Rituximab in refractory lupus nephritis. But I would argue, and I apologize for those of you at my talk yesterday, the problem remains steroids. We've heard so much at this meeting and at the Lupus Academy before, they're just not good things. And we've taken a different approach, which is we've tried to get rid of steroids. We've been using a steroid-avoiding regimen since 2006 in all new or relapsing lupus nephritis if they're not already on steroids and do not have RPGN or cerebral lupus. And we've established it as our first-line treatment protocol. They get a pulse of methylpred, a little pulse, not a big pulse, you don't need a big pulse, and a gram of Rituximab at day 1, and we repeat that at day 15. We start also at exactly the same time we start the methylpred and Rituximab, mycophenolate mofetil. We start at 500 milligrams BD and we titrate it to trough levels. Most of them are on about 750 to a gram BD, and we don't give them any oral steroid. This is 50 patients. This is now finally in press in the annals, and I hope will be out soon. We've got median follow-up of 163 weeks. They are older. This is our practice. We're a nephrology practice rather than a primarily rheumatology practice. A suitable mix of ethnicities. We do have some with negative serologies. These are all diagnosed on biopsy. They 58% have extrarenal manifestations, some of them quite severe. We have class 3 and class 4. We have a lot of pure class 5s, and most of them are relatively treatment naive. And they do extremely well. So this is a Kaplan-Meier. This is time since treatment, the number of patients in follow-up, and the proportion achieving complete response or complete remission and partial response. And you can see by 12 weeks, 18% in complete response, by 26 weeks, 32%, and in the ARMS data, that was 8.5%. And at 52 weeks, 52%, and in the LUNA trial, that was 26.4%. We do start to see relapses, but they've had very little immunosuppression, and they're often easy just to redose with Rituximab. We're not routinely redosing. Stopped. It's decided the time has ended. Okay, it doesn't matter what your class is. At baseline, it takes the same time, and you get the same degree of remission, whether you're class 3, class 4, or class 5 at baseline. 24 patients hadn't achieved complete remission by 52 weeks, and I only show the detail of this slide to say that those patients who still have persistent proteinuria that's not falling, we rebiopsy them. And what we show is that a high proportion of them have histological remission with no new lesions on light microscopy and no new deposits on electron microscopy, and they go on into complete remission over time. And in the LUNA trial, were probably a significant proportion of those patients who at 78 weeks were in biochemical remission, probably on biopsy were in histological remission at 52 weeks. And I would argue we need to be doing these biopsies more often. But the most important bit of data is that of the 50 patients, 5 had to switch for non-response or non-tolerance of the regimen. But of the remaining 45, only 2 have had long-term oral steroids. 1 because she got terrible pericarditis, and once she's on it, once you're on steroids, it's nigh on impossible to get her off. She's down to a milligram, she's pregnant, she'll stay on her milligram for while she's pregnant, but she's in complete remission. And 1 had 3 short courses for cutaneous steroids, but 43 patients had no oral steroids. So we're going to do the trial. It's the Rituximab trial. We're going to compare our regimen, methylpred, MMF, and Rituximab, with MMF and methylpred and steroids, the ARM MMF regimen. It's an open-labeled, investigator-led, randomized, multi-center controlled trial. We've already got a lot of units interested around the world. We'd be very happy to have South American units. It's a non-inferiority trial. I will put good money on the fact that if this is as good as the MMF, but you can get away without the steroids and you get improved safety, people will swap. The primary endpoint is complete remission at 1 year, but we're going to follow everyone for 2 years because we want to see the safety signals. We've gone for a high complete response rate in the control arm, a 20% non-inferiority margin. We need 252 patients. This is the group involved. I'm the chief investigator. These are my nephrology colleagues from at the Hammersmith and David Jane, a very eminent bunch of rheumatologists. We have a pediatrician, Terry Cook's our renal pathologist, and it's being run by Imperial College Clinical Trials Unit. And if you're interested, that is my email. So in summary, I think we are heading towards a more rational approach based on the understanding and pathophysiology of lupus nephritis. I think it's extraordinarily unlikely that we're going to have an equivalent of TNF in rheumatoid and have one agent that treats all. It is a very crowded area. Those 4 trials alone need 1,210 patients, so we're fighting with each other. But the new trials are definitely improving on the old trials by learning from their data. But we need therapies that reduce the dependence on steroids, that are safe in the long term, and that reduce flare rate. And the trials, I think Ring and Rituximab will address 2 of these very important questions, and I like to think that the future can be steroid-free and biologically rich. Thank you very much.
Another wonderful and thought-provoking talk. I think if there are any burning questions, we could hear maybe 1 or 2. We're over time, and then we could take questions up in front.
Hi. I would like to ask you if at this moment, do you think that the multi-target therapy in lupus nephritis combining glucocorticoids, anti-calcineurin, and MMF have any role in the management of lupus nephritis?
I think the multi-target therapy is very interesting. The data that I've seen are very strong for very good responses. But in a way, it seems to me a backward step, because going to steroids, MMF, and tacrolimus is like the old days of transplantation. It's a huge burden of immunosuppression. So I'm not sure there's to be gained. I think TAC and MMF as an approach would be very interesting. But I think adding 3 agents, you must be going to see safety signals long term. But I think the role of TAC is very interesting.
McCune, originally from Boston. I want to suggest that maybe in your trial there's a second message, which is that MMF with levels is much more effective than MMF without levels in some patients. Maybe this is one reason steroids can be spared, because there are huge variations in levels achieved with the same dose in different patients.
Yeah. Well, we use it. I was a convert because my colleagues have been using it in transplantation when we merged, and I hadn't been used to using it. And it's really quite eye-opening. There are patients who are toxic on 500 milligrams BD. I think there is a risk when you target to levels that you get to a level and you don't push it high enough. And sometimes if we see persistent proteinuria and you just push the MMF up a bit, then you actually get a better effect. So I think you should be aiming higher. and perhaps the trough levels in nephritis need to be higher than in transplantation. There's some data out there, but it does avoid serious toxicity. We almost never see leukopenia. We get very low rates of gastrointestinal side effects, and we almost never have to reduce the drug for toxicity. And you certainly avoid overdosing a group of patients, so I think we definitely would. We've got virtually no one on 3 grams a day. About 2 patients in several hundred. I think it's the way forward.
Quick question. Here, quick question.
Gunnar Sturfeldt from Lund, Sweden. We know that several studies have shown that interstitial inflammation is very important for the long-term prognosis in lupus nephritis. And we also know that in the pathogenesis of those lesions, activation of the alternative complement pathway is very important. One treatment that you didn't mention, possible treatment, is blocking C5a receptor, and I think that might be an alternative in individuals with those
I agree with you entirely. I think it's one of the most attractive possibilities out there. The problem is there's no evidence to quote. There's a phase 1 trial that appeared to have effect on complement activity. There's very nice data in hemolytic uremic syndrome, but it's not being used in lupus nephritis. It is all peed out if you're very nephrotic, so you'll have to alter the dose. It's also currently the most expensive drug in the world, so it's not a practical alternative, but I think as a therapy it's extremely attractive, and there's new agents coming on that I'm sure will get trialled. In fact, the chemocentric anti-C5a is being used in vasculitis first line rather than lupus, but I completely agree with you. It's a very, very attractive bit of pathway. It was on my overview slide.
Yeah, and data from animal studies really support that.
Oh yeah, I'm sure.
We've used it in one patient and it was extraordinary.